would like to call on you to invite Ethna to address us. Thank you.
Good morning, everyone, and thank you all. Most people know me in this room as Ethna Cusack, and I work, when I meet my colleagues, I think I've worked in most areas in Dublin, so I suppose it's an indication that we're getting old. But anyway, I suppose just to say that there is the Vision for Psychiatric Mental Health Nursing. There is a copy in your packs, and this strategy was developed by the Office of the Nursing Services Director through engagement, collaboration and extensive consultation with all of the key stakeholders nationally. You have the Office of the Nursing Services Director, the National Service Users Executive, Department of Health, the Mental Health Commission, SIP2, PNA, the Mental Health Nurse Managers, and the National Council at the time were involved and co-funded that piece of work. It was an extensive piece of work. We actually, there were over 1,000 questionnaires sent out nationally and returned. There were focus groups held in every service in the country with clinical nurses, service users, families and carers, senior nurse managers and executive clinical directors. We also accepted submissions from a variety of, we had about 26 submissions from service users groups, volunteer organisations and professional organisations and groups. So it was an extensive collaboration, and it provided for the first time a nursing strategy for nursing. And just before I actually talk about the strategy, I would like to acknowledge Fionnuala Killoury is here today, and Fionnuala was the project officer on this and co-authored that report with me. So I would just like to acknowledge the work she did. She actually did a lot of work in a very short period of time. So thanks, Fionnuala. The strategy provides direction for the further development of the role of the psychiatric nurse in Irish mental health services. It will strengthen both nursing practice and leadership within a client-centred, community-based, recovery-orientated, interdisciplinary environment. It will support standardisation of evidence-based clinical practice within psychiatric nursing nationally. And it will set a clear and informed roadmap for the profession for the years ahead to respond to service users and family needs. It also identified how mental health service delivery structures and legislation needs to be aligned to enable the full implementation of Vision for Change. And like all good reports, I suppose when you actually do a piece of work like this, you identify what's working and working well in the system, and you also identify the gaps. So I'll just talk about the gaps, I suppose. So just to say the key findings, some of the key findings in this, and I suppose I'll give you three, the larger findings, was the dominance of the medical model within the mental health services across the country, and that was a major finding, and it was consistent across the country. The second one was the variation in the type of services and nursing services being delivered, and the clinical interventions that were being delivered across the country. And there was it was interesting. One of the service users said, and I quoted him before, and he said he had been on holidays. He was from Donegal, and he'd been on holidays down the south of Ireland, and he said he expected to get a similar service in the south as he got in the north, or he was from the south and went to the north. I can't remember, but he expected to get a similar service, and he said it didn't remotely resemble the service that he'd been getting. He said, if I went to McDonald's or bought a burger in Donegal, I'd expect to buy the same burger in Kerry. And he said it didn't look the same, it didn't taste the same, and it wasn't anything like the same. So the third major finding was the requirement to recovery-proof all of our systems, processes and practices, which we carried forward from an institutional model, and both from a professional and organisational perspective. And I know Professor Julie Repper is here today, and I think Jackie will also talk about the importance of looking at the processes and the systems that we've inherited from a different model. They were the major findings. All of the findings are outlined in the document, and they were themed in the following categories. And the categories in the document looks at adopting a recovery approach, improving outcomes and service quality, developing clinical nursing capacity, and enhancing organisational effectiveness. And I suppose adopting a recovery approach is actually, it infiltrates all of the recommendations. So our implementation plan, as you probably are aware, there was a restructuring of the Director of Nursing role within the HSE, and there are now area directors of nursing. So that restructuring process took place earlier this year and is completed, and I suppose it probably held up the implementation process for this report. However, there is a national expert reference steering group will be set up, and the terms of reference for that group will be to lead, advise and monitor the implementation of the recommendations of this report nationally. That steering group will coordinate the implementation through regional groups within the HSE. It will facilitate and support the standardisation of clinical practice within nursing in mental health services nationally. It will monitor and evaluate the progress on the recommendations both at regional and national level. It will oversee pilot programmes and studies in some instances and areas as appropriate. It will provide advice and support as appropriate at regional and local level, and it will report and make recommendations to corporate HSE and the Department of Health as appropriate. And there will be implementation working groups at regional level, and their terms of reference will be to lead, advise and monitor the implementation of the recommendations at the respective regional level, to endorse the objectives and priorities of the national report at regional level, to advise the National Implementation Group for implementation, to provide a regional forum for nursing and mental health nursing relating to issues in mental health service delivery, to initiate pilot studies and projects as appropriate, and to report 4 times annually to the National Implementation Group. And then we hope to actually formally review progress after 5 years. And we'd agreed that there would be a nursing conference every 2 years. So we published the report last year, so this is, I suppose, to kick off the nursing conference. Just to let you know what progress we've made to date. To date, we have developed a number of clinical skills programs. Jimmy Lynch is actually presenting one of those today, is the Psychosocial Intervention Programme. And James O'Shea is presenting another one. It's Basic Cognitive Skills for Practice. We hope that those programs will be rolled out nationally across the country and available as core skills for all psychiatric nurses. There has been a development of 37 new clinical nurse specialist posts in self-harm in emergency departments and 7 in suicide crisis assessment in primary care. And I know Steve Lamb is presenting on the SCAN initiative, which was rolled out in Wexford this afternoon. And Alison Van Leer is presenting on ED, the Advanced Nurse Practitioner role in ED. The 37 new posts have been recruited and will be coming into the system very shortly. We're also commissioning a risk assessment framework for nursing for CAMHS and adult mental health services, and we hope to have that framework developed early next year or during the year next year. That's the progress to date. I suppose the ONMSD presents masterclasses from time to time in mental health. We had Dr. Grania Fadden over, we had Dr. Julie Repper yesterday, and we hope to roll out a number next year to support the clinical programmes. So what do we need other than what I've presented? I suppose we need leadership at national, organisational and local level. And at a professional level, I think nurses have always been leaders. And I think nurses have actually rolled out and developed a huge number of new developments in mental health. So I suppose this conference is to support nursing and to encourage you to continue leading. And just remember, I suppose, success is a journey and not a destination. So we'll be on that journey for some time for mental health. Thank you.
Good morning, everybody. First, I'd like to say thank you, Tricia, for that glowing introduction, which usually sets you up to fail. And I want to say a very special thank you to Ethna for inviting me here this morning. And a big welcome to all of you. Some of you I have worked with in my past career, and some of you have been students. So when she said lecture to you, usually you lecture to me, and that's why I stay involved with the undergrad students, because I seem to learn far more from them than they learn from me along the way. But it's my pleasure to be here. I have 30 minutes to kind of set the scene around recovery, whether it's an emerging paradigm or unfulfilled aspirations. And I know I'm getting old when I see the technology getting smaller. But I looked at this morning, I thought, oh goodness, how am I going to see? So bear with me as I squint at it. No, this is the next thing that looked wrong. So I suppose I have set myself 4 brief tasks for the next 30 minutes. One is just to give you a quick background to recovery, and then maybe to talk about who is recovering and from what. And then maybe just to briefly give you some state of play within Ireland in terms of some of the initiatives that we have, that has been developing. And I suppose equally as an introduction, because some of those initiatives you will hear more about during the day. And then maybe to talk briefly about some of the challenges for the future, because as Ethna said, we are really only starting on the journey. So I suppose if you look and think about recovery, and we often think about it in terms of the service user movement, but there are 2 kind of different interrelated sources of discussion when you look at the literature, or you could, what Foucault would call maybe discourses of resistance that have been challenging kind of traditional wisdoms. One must be from professional-led research, and then there is the other side, which has come from the service user movement. You know, in the professional-led research, if you go back to the World Health Organization's international pilot study on schizophrenia back in 1973, and we've had numerous studies since then, that that study did was open a debate and set, because it demonstrated, I suppose, that people with a diagnosis of serious mental illness had quite significant outcomes in terms of their ability to resume personal, social and vocational activities. Whereas traditionally in a lot of this group of people, there was a kind of a diagnostic pessimism, for what you would call it, or a prognostic pessimism among clinicians. That there was, we gave people a diagnosis and then we nearly scripted the outcomes in our head in terms of poor outcomes. And I suppose this was one of the first studies that started to challenge that. And we've had some other studies since then. But I suppose the big driver in recovery movement and in pushing us to think differently has come from service users. And it has come from a lot of the research, originally starting out with maybe individual narratives and then more systematic qualitative research that challenged a lot of our thinking. And it challenged us to start to think that people can recover and lead fulfilling and meaningful lives. But I suppose not alone was that one of the agendas of this, but most people that were writing with that had a very strong political and social justice agenda as well. It wasn't just about a clinical agenda. And what they were advocating, and what the people are still advocating for, is a radical shift in how we think about mental health issues and how we respond to people who experience mental health and mental distress. And I suppose the other big drive in their writing and in their political campaigning is for an urge for a greater distribution of power between the institution of psychiatry and people who use the services. And I suppose that is one of our biggest challenges, that the services have been quite strongly dominated by the expert practitioner. And how do we shift that, and how do we redistribute power at all levels within the services? And I suppose the other issue was the need for a recognition of civil and human rights, and not just in terms of a recognition for people's rights to engage in all the things that the rest of us would engage in terms of social activities, community engagements, but equally a civil right to define their own experiences. Now, and from those 2, I suppose, what you would say, different camps, we have given rise to, I suppose, different standpoints on what we talk about recovery, and that usually depends on who's defining it and who's measuring it. So we have, and Mike Slade in his work would talk about the three kind of types that people debate about clinical recovery, whether recovery is about relieving symptoms, is it about relapse prevention? Is it about risk management? Is it about functional recovery, which comes nearly out of the traditional old rehabilitation kind of thinking? Is it about maximising, I see, people's skills to work, attend school, form relationships and live independently? Or what is personal recovery about? Is it about people's own personal meaning and how they redefine themselves beyond the illness label that we give people? So I suppose a lot of the times we think about that recovery is about a personal journey for service users, whereas I suppose one of the things that I just wanted us to think about today is that recovery is for all, that we need to think about it in the context of people who use the services, we need to think about it in the context of families, and we need to think about it in the context of practitioners and organisations in terms of what it is that we need to be doing and how we need to be thinking a little bit different. So if we look at it from a service user perspective, I suppose what the literature is saying there in terms of that recovery from their perspective is very much about a pilgrimage of self-discovery, that it is a personal, unique experience that for each person, that is not linear by any way. It has various circuitous routes. But I suppose that what it's the message, I suppose, for us as people who work in the services is that people are recovering from multiple things. And some of them are things that we have very successfully managed to induce in some of our traditions and some of our practices. And so I suppose the take-home message from a lot of that literature for us as practitioners is that people are recovering not just from the impact of the trauma that led to the distress in the first place, but they're often recovering from the negative impact of medications and other treatments that we give them, the sense of being devalued and disempowered by the services when they come into it. I suppose the lost opportunities, and especially for young people who may have experienced mental distress in adolescence, and we know that these are a group of people that will fall out of education early, but the lost opportunities for education, the lost opportunities for employment, and the lost opportunities for friendship. And we equally know in terms of employment the number of people with mental health problems in terms of how their statistics vary and stack against the employment rates in the rest of the country. I suppose they're recovering from fractured relationships and friendships that maybe have ensued with the mental distress and where people have pulled away from them. And most importantly, I think that's coming through is that the need to recover from the stigma, or what Goffman would talk about in terms of spoilt identity, and the internalised stigma that people feel because of the way they have experienced discrimination and social exclusion by society, as well as the internalised stigma that comes from being labelled with a mental health issue, whether that be schizophrenia, personality disorder, and how that whole diagnosis becomes internalised as nearly a master status, and the negative impact of that label on people. I suppose the messages that they're strongly giving us when we look at their recovery narratives as well is not just in terms of the whole issue of what they're recovering from, but this is a synthesis because there's quite a vast array of literature out there on people's recovery journeys. And what their take-home message to us is that what's needed is connectedness. That in terms of we need to start to look at how to help people build connections with family, with significant others, with peer and support groups, with support groups within the community, and I just hope that's not mine. Because it has happened where I told people to turn off the mobile phone and then it was my own that rang. So, and I suppose what the message is here is that we need to start to think in terms of social inclusion and how do we help people connect into the community. I suppose the other message that they're saying to us is that one of the big things is about hope and optimism, that they need to meet people who believe in the possibility to recover, who can hold the hope at times when they're not able to hold the hope. We need to help people in terms of re-engage in nearly a redefining of their identity, that we have given them kind of in some ways a master status, status of mentally ill, and how do we help people to work through and engage in redefining that, or how do we stay back and let people do it on their own? Equally, they're talking about, people's message to us is about the need for looking at the meaning in the mental health experience. And I suppose one of the things that, especially for people who are traditional type researchers and everything has to be measured, the whole area that is going to challenge us, I think, in recovery in the future is looking at the whole spirituality dimension, because that is interesting. Nearly in every paper you read, that is now coming to the fore, and it's something that we have traditionally have given lip service to, or we have constructed it nearly in terms of religion. And I suppose the other piece is that what people need is an empowering service rather than a disempowering service, where people are helped to gain personal responsibility and control over their lives, and where we start to focus on people's strengths. When we think about it from a recovery from a family perspective, and I think that this is where we don't have the same level of literature. What we do have is quite a lot of literature that looks at the burden of illness, which sometimes doesn't sit well with me, because I think that in some ways we have researched it in family in the context of that the person who has experienced the mental health problem is seen as somewhere a major problem. And I think that the word burden of illness, maybe we need to start to think of other ways of researching and seeing, you know, what is it positive that people bring to families, even in that level of distress. But so for what we do know in terms of from the families and from some of the smaller studies that we have done, and through the Mental Health Commission and through the HRB in terms of engaging and talking to families within Ireland, is that they are recovering from the grief, the pain and the guilt. They're equally recovering from fractured relationships. They're recovering from and need to recover from the courtesy stigma that they experience by having somebody with a mental health problem. But what really resonates throughout all those pieces of work is their sense of exclusion from services, and that, you know, that we have not really engaged with families, and that they themselves have started to imbibe that narrative of pessimism that we have given to people who use the services. So I suppose when we talk about recovery from a family perspective, we need to be thinking about that they are rediscovering the belief that the family will and can recover, and a self-awareness in how they can help or hinder that recovery. And I think that we need to look at both sides of it. From a staff or a practitioner or an organisational perspective, I suppose this is our biggest, one of our biggest challenges, because what we are being asked to do in the recovery is we're asked to think differently. That this is not just about adding on to what in the traditional way we think about service provision, but it is about thinking differently. And once we think differently, you know, because I suppose thoughts do frame actions, that if we think differently, then we may have the courage to act differently and take that step and be different. So I suppose what recovery is asking us to do is to think about, in terms of how the current service and the current narrative in services is very much focused on diagnostic and symptoms, even though we think in our heads that we have moved, and I like to think we have moved. But when you meet people who use the services, again, a lot of the times they still see us as thinking in terms of diagnosis or symptoms, or what Fiona Shaw calls that we are really good symptom spotters. And I think it's a very apt description of us in her book. We are very much, in terms of care plans, are deficit or symptom orientated, and the need to think differently from that. And I suppose that even though we think that we're engaging in equal relationships and that we're having conversations, in a lot of the times our conversations and our dialogues are pre-scripted. So our idea is that we get people to believe what we want them to believe. And I suppose that to me is a monologue, even though we may think that two people are speaking. And it's challenging us to think about how do we undo that type of unequal relationships and the disempowering services that people are talking about. I suppose the other thing, and we're caught here, and I think this is going to be our big challenge for the future, that we're, in terms of that we are very focused on being risk averse, and we are caught within, I suppose, a professional framework and a legal framework. And I think this will be our challenge in terms of looking at how can we shift from being risk averse to much more in terms of taking and giving people the honour and dignity of making bad decisions. You know, there's none of us here in this room that haven't made bad decisions. And known the shame and humiliation of the bad decision. And we have managed to grow beyond it and that. And I think everybody has the right and to the dignity of making poor decisions. And I suppose as well that our current services perpetuates nearly exclusion, that we are very much focused with the individual within the service rather than needing to open out our thinking in terms of focus with helping people to engage with community, and maybe thinking about that some of our services need to be very not ran by mental health practitioners, that what we need to be doing is working to get people within to engage with community, and that maybe the people who experience the service, and I think Julie will talk a little bit more about that in terms of the Recovery College and peer working. So I suppose what we're being asked is to move from that kind of paradigm of thinking to start to think about the person not in the service, but the person who is living a life with hopes, dreams and wishes, that has a right to meaningful choice, that has a right to true partnership working, that has a right for us to start to think about what are their strengths and their assets rather than their deficits, like we seem to do. It's about, in a lot of cases, looking for what I can't do. And I mean, anyone that's engaged in education will tell you the first lesson I ever learned was the most important thing was to give the students confidence in what they could do, and to start from that perspective, and you'd get things, a lot better outcomes. I suppose it's about helping people to have responsibility, but with appropriate challenge and support. That we need to think about social inclusion and building connectedness. And I suppose we need to think about what, in terms of education, we talk about mentoring and coaching rather than sometimes in terms of therapy, that if we start to think in this other way. So where are we? I suppose, so there are some of the challenges in terms of from an organisation and from a practitioner point of view, and equally from engaging with people who use the services and families. So where are we in terms of to date? I suppose when you think back that in 2006, we've 7 years since the first time the word recovery entered the lexicon of Irish mental health practice with the vision for change. And it was in 2006, in that document, it said that recovery should be the cornerstone of our mental health practice. Since then, we had a discussion paper in 2005 from the Mental Health Commission. In 2007, the Mental Health Commission put recovery-focused approach as one of the standards. We had the recovery framework in 2008, and then we had mental health reform just in 2013. Produce their document on what people should expect from a recovery-orientated mental health service. And we recently, from a nursing point of view, we've had the Vision for Change document, the Vision for Psychiatric Nursing and Mental Health Nursing, that again, one of the major pillars within that is on recovery. But as Walsh et al., who are my colleagues in DCU, says that although the shift from traditional psychiatry or biopsychiatry to recovery can be achieved on paper with a few deft strokes of a pen, actualising the shift within practice is far more challenging. And I think that is very, very true. But we have managed to do certain things within Ireland. And I suppose I just wanted to give you a quick brief overview. I suppose one of the big national projects is the Advancing Recovery project, which started in the Mayo Mental Health Services, and there's about 7 other services that have been involved with that. And I suppose that project is set up on the Sainsbury Centre for Mental Health organisational challenges, where it is looking at creating the culture of recovery, changing the nature of day-to-day interactions, looking at the whole personalisation and choice, looking at service user-led education, looking at a recovery education centre, looking at the risk assessment, redefining how service users are involved within the services, and transforming the workforce. And they're doing a lot of work on peer workers, community connectors, individual placement coordinators and support workers in Mayo. And there are other, as I said, 7, but that's at a very early stage in its development. Other projects we have, and you see, if you haven't heard of them, they are the mental health trialogues, and they are happening in different parts around the country, and some of this is being funded by Genio. And the trialogue is really about creating a neutral space for service users, families, practitioners and communities to develop a shared understanding of mental health issues with a view to transforming thinking and action on ways to deliver services. And I suppose these are really exciting projects, I think, in terms of when you start to think about getting communities, service users, families and practitioners together in the one room. The other projects that you will maybe hear about today is the OLAS project, which is a project that has been developed in collaboration with service users and families in Selbridge. Again, it was about responding to some of the needs and expressed needs of families around the need for information, and that's in its early stages. Again, it's being rolled out into a number of services in the East Coast. And it's also being evaluated, and so far some of the outcomes of it are showing some positive things. But I think one of the things about this is that it is both clinician and peer-led. So it's not about the clinicians leading out in the education. So each programme, if it's service user focused, it's a clinician and service user led, and family programme, it's led by a family member and a clinician as well. We also have the cooperative